public comment.
I don't have any public.
Okay. Moving on, we have the consent agenda with the regular minutes and special meeting minutes and the calendar. I've already submitted the calendar to Jen.
We'll move that the consent agenda items be approved and presented.
I'll second that.
Okay, moved and seconded over the cookies for approval of the consent agenda. All those in favor?
Aye. There's a spelling change I'll show you in
Okay, spelling.
Cookies are with 2 O's.
It's YS, KYS. Anyway, October 2018 financial report. Cheryl, you're on.
2019.
I already have
2018.
Oh, yeah, thank you.
Read only.
A few more days.
Oh, yeah.
Right, I don't have it. Oh, there it is.
On your desk. On your desk.
It is, so it has to be at that time. You just can't make changes to it. Well, darn it, you can't make changes. Okay. So off we go.
That one's green.
Okay, I have the labor records financials that I need to remember to send out to you. Sorry about that. The hospital for this month of October, 4 months in, we had a total of 305 patients, which is very close to our average of 309 patients so far this year, but below our average last year of 334 patients a month. Our biggest declines continue to be in surgery and in our surgical departments, both in and out. However, to make up for that, our ancillary services continue to be extremely strong. Year over year, our lab is up 5.9%, radiology is up 6.2%, rehab is up 4.3%, home health is always kind of up and down, and health clinics are up 7.8%. We can note that we are adding Goose Lake numbers into our clinic now because they are part of the hospital. And we could probably break them out, but I noticed that we put
That's
them
fine,
in
that's
there
fine.
this time. Yeah, so, all right. We'll figure out how we want to report Goose Lake this time. And if you looked at your detailed financials closely, Goose Lake is a separate, and it's called Alturas Health Clinic. Okay.
We are in the process of changing the name.
Right.
And for a couple of reasons. Number one, it's a good opportunity. Goose Lake, while we selected that, you may recall the process that we went, well, not everybody was here. We looked at a way to come up with a name that would be, we thought, merging both Lake and Modoc County, and Goose Lake seemed to be the physical structure or physical entity that would bind us together. It turns out people in Modoc County hate Goose Lake. So it really didn't help our naming process. So we thought often over the years to change the name, but now is a good time. Also, it'll be easier when we redo the rebuilding. To have different so it'll make it easier like that.
So what is the name going to be?
It will be Alturas Health Clinic that matches with what we call the Lake Health Clinic here. So it just used, the pattern is the same.
What is their health clinic called? That's
Modoc Medical
It's
Center.
Modoc Health Clinics in
Modoc Medical
Modoc
Center.
Medical.
Okay, so gross charges for the month were $3.35 million, which is a new record high. Our collections on AR for the month were $1.85 million, which is really just about average.
Well, we expect to see next month go up a little bit because of this price charges.
No, because it'll take a while to roll through, because once those charges have to go through the cycle of billing and things like that. In fact, this month we just finished with a low month.
Okay, so typically, how long does it take, from the time it's charged to?
Days in AR.
Days in AR,
Yeah, 80 days.
Okay, 80 days, okay.
Yeah, 80 days.
unless they have insurance, and then it's closer to 45.
Yeah, truthfully, a lot of them are less and a lot of them are more.
Right, I understand.
Yeah, okay. So the days in AR went up a day from 79 to 80. November was tough because of Medicare issues, but as far as the revenue cycle improvement and the consulting that we had, I would hope that we would start seeing some improvement in December.
I do hope so. The visit we had with the workflow optimization specialist really helped. Right now it's really helpful getting things done. We had a little glitch Medicare had last month, but that money's trickling in. But we'll see. I'm going to do a bit more analysis on it tomorrow.
Yeah, we keep looking at it. But I didn't expect it would happen right away, so not too surprised. Okay, so this is our days cash on hand, which has dropped all the way to 66. And that's probably an all-time low. So we did receive $1.5 million for our tax money in November, so that actually would only bring us up to 85, and we need to be at 90. So we are still looking at reducing spending and increasing collections to get us up to where we need to be and stay there. Okay, profit and loss for the month. For October, obviously revenue-wise, it was a very good month. The net revenue is 2.6, which is 39,000 over budget. Our operating expenses, we're under budget here, we're over budget here. Our net total expenses under budget 26,000. So and really our big event for the month was that $150,000 donation. So that gave us a net for the month of $194,000, which is $167,000 ahead of budget. Year to date, our revenues at net revenue 9.7, which is $600,000 below budget. Our wages and our benefits are quite a ways under budget, and our utilities and services is almost $400,000 over budget. Operating expenses are $100,000 net under. Depreciation, interest, total expenses $10 million. We're 156 under. So our total operating gain for the year, or loss for the year, is $1.1 million, almost 1.2. We are $460,000 below budget. My next slide, I'm going to look some more at this number right here. So non-operating, we're doing pretty well. Our net is not bad with a loss of 106. It's 200,000 behind where we had expected to be at this point.
Do you have any ideas why you're so far off budget on the materials and services?
I do. I'm going to show you. Well, I've got some ideas. Really what I ended up doing was saying, how come I'm 460,000 below an operating loss where I wanted to be, less than where I thought it would be. So expenses are part of it, but revenue is a bigger part of it. The lack of our orthopedic surgeon right now has $1 million impact on our budget. That's net revenue below budget. That's huge. Acute is a little bit slow, but not really a big surprise, and that's all about revenue, not expenses. Lake Health Clinic is getting better, but their revenue is $283,000 below where I expected it to be. But I do see those numbers starting to increase.
And that's combined numbers you were talking about earlier too, right?
Yeah, those clinic numbers, this number right here is just Lake Health Clinic by itself.
Okay.
Actually, when you pull Goose Lake, now Alturas Health Clinic, into our financials, and you take their benefits out, they don't look as negative. So they actually were kind of at a break even. So Lake Health Clinic is running behind, but is gaining ground. Public health right now is behind $122,000, and I think that has more to do with the fact that we're trying to transition from a non-existent EMR to get them on the EMR. They don't use EMR, they use paper. So right now, we're not really billing. I don't think that's gonna make a big giant difference in this number, but we are definitely on that steep part of our learning curve with public health about what's going on, where do we get money. There's some parts of their business that we're just not able to bill yet. We will be able to go back and catch up, but we gotta learn what we're doing.
Have we done additional hiring there as well? Same way we did with behavioral?
No, I think we've actually reduced.
We're down,
numbers.
yeah, we have.
I think it's part of it is figuring their budget cycle and how the revenue from the county goes.
Yeah, that's a big piece of it. I had to apply to the state of Oregon for a new number. I don't even totally understand what I'm doing. I just know I'm doing the right thing because Oregon's their lane. But in order to bill for the at-home stuff, you have to get this new number because you now are at the hospital instead of the county, and so I'm waiting on that number so I can go back and bill a few months of that home visit stuff. And, I just have to wait. I just talked to Oregon the other day. It's on the way, but it's not here.
So any idea on the backlog of how much?
Oh, it's not $122,000. If we're lucky, it's gonna be, I have no idea, but I bet you it's not $75,000.
Yeah, not that much, because a lot of the items that are waiting to get input are immunizations, flu shots, really.
Yes.
Keep in mind the county.
Yeah,
they
5 to
made
5%.
transitions so that we would be able to talk about this kind of an issue once we've gotten into this event and go through those issues. It's been such a short, quick couple of months. I mean, really, this is through October, so it's really only 4 months.
Yeah, and it's a huge culture change for the people in public health. It really is. So we're trying to not jump in and just make life miserable for everybody. We're trying to understand what they do, why they do, and we're trying to help them understand why we do the things and have them start picking up our processes and our procedures in their clinics. So, but it's a big difference from regular.
Where do you have your, what do you call it, mental health program
In where?
in your?
Well, this I just pulled out the biggest gains and losses from the
Okay.
detailed. So Wellness Center is a little behind, but I didn't put them on this sheet. Because I didn't see them as being, I'm just trying to pull out what are the biggest reasons why we are where we are. IT, so IT, the expenses are over budget by 30,000, and I guess I don't think that's that bad when you start to think about the amount of time we have spent moving people and buying new equipment and setting up new, we had the Headland building that had to get all decked out, and we expanded Marius, we went over to public health and did a lot of work there. We got all the work done in our new clinics, we had to move people down there, now we're going to move up here, so, I don't think that's too bad. Same with plant. We're $87,000 over budget. We're looking at that. We had a few major, repairs that were unexpected that I don't know they have a budget for. I'm going to look at that number some more because I don't totally satisfy myself as to that number yet. So I'll have some more answers in a few days if you want to know. So these were the big losses, that's pulling us down. But on the other hand, lab, their net bottom line is $172,000 over budget. Radiology is $400,000 over budget. Contractual expenses are naturally less than we budgeted because revenue is less than we budgeted. So that's just the natural way it works. The general contributions are $140,000 over what we budgeted. And right now, our benefits are $129,000 under budget. I do anticipate that number's gonna level out by the end of the year because the cost of benefits go up on January 1. Our health insurance, we calculated today, is going up by 5%. Now we split with the employees. I'm sorry, did you? Okay.
And we have budgeted for the full year, anticipating the cost. Right?
Yes. Yeah, I just spread it out during the whole year because I really have no idea how much it's just a guess on my part.
So physical therapy is pretty much on budget.
Yes, they're very close. Yeah, I mean, they're ahead of budget, but they're not a huge, but, I mean, so this I only showed you, 407 and 460. The rest of it is just smaller parts that are up and down.
So as we roll forward, we're gonna start looking at maybe some capital expenditures we're not gonna be able to make.
Probably, yeah. I mean, I
Or
think
we
we
have
need to think
budgeted
about,
items that we may have to defer.
yeah. Yeah. I think one positive spot is, I mean, we've been working on the OR remodel, which I'm sure you guys are gonna talk about later, which has caused some slowdown in surgery. But Dr. Chang is doing well, and I mean, my sense is he's gonna do a lot more surgery than he thought he even might. So he might start eating away at that ortho surgery cost. And that would be great, so. Okay. Okay, balance sheet, really no changes month to month. Our cash went down, our fixed assets went up a little bit as we paid Detroit. Right now, we only have 1 month outstanding, so $337,000 that we could borrow for, on that bill. Otherwise, really, no changes. So any other questions on Lake Health District? Okay, so then we can look at, oops, I screwed that up, I gotta get rid of them. Okay. So for Lakeview Gardens patient days, for October, we had 541, just about 17 patients in long-term care and about 7 patients in the assisted living. Our revenue for the month was $200,000, which is right at average, it's right there. This is the first month where contracted labor exceeds our in-house labor. And that just is going to continue. It's painful. So the last month was $153,000. Lake Health Medical Supply, they had kind of an average month of $27,000. They had a loss for the month of $36. We have hired a DME consultant to come and help teach us, Brian and Quentin and I. First of all, he's helping us prepare for our Medicare survey. So he's been here for a week. He's going to be here another week next week. He really was amazing. He taught us a lot. He was extremely knowledgeable. I think he's going to help us get our processes and procedures in place, look at service lines, product lines, how to be the most efficient and effective we can be. I think it's going to give Brian a lot more confidence in what he's doing and how he's doing it. I think it's going to make a big difference. It's going to cost a bit, but I think long run, it's going to definitely improve our profitability. So that'll be good. But for now, we'll have to forego that profit. And that's all I got.
Okay, any questions? Comments? Okay. Just like medical services,
That was it.
that was it, okay. So we'll turn this over to Charlie on the construction update.
So, God bless you. We have 2 projects that we're working on. As you know, at the last board meeting, a week and a half ago, you approved a budget to go forward with EMS building. We have not yet started the discussion with Lakeview Disaster Unit in the design phase. We're looking at setting that up to have that discussion. Hope to have it done pretty soon. Part of it is getting people together, especially at this time of year. The clinic remodel. We just finished a couple of hours ago having the consultant, the facilities and planning expert here from the state, Salem. And there were a couple small minor items that we wanted to have done. We'll take pictures of those being fixed and sent off, and we should be able to move in. What that means is, rather than on the 10th moving in, it's been moved back 1/17. Bit of a delay, but not a significant delay. So we're all ready. Cheryl said we've got computers in many of the patient rooms. We have exam tables. They're just the final adjustments. A droid is frantically trying to get all these things done. So we will be seeing patients on the 17th in both the specialty clinic and the expanded Lake Health Clinic. So that's a positive. We are in the second phase of our operating room repair. We did it in 2 phases. When we started the plan to get this, it was very concerning with Dr. Skrinsky to make sure that we were doing construction when she was not here. So we had set that up to accommodate that. Less of an issue now, but they're finishing the final bits and they should be done, I believe it's either the end of this week or in next week. So the new sterilizer and the new cleaner the new sterilizer is in, they had to adjust for the new washer in the expanded space. So it's going on. It's always an amazing thing when you do construction. We had our assisted living survey this week. They came. And on Monday, we had pipes frozen in one of the rooms in the assisted living and 2 in the long-term care. So we had to quickly work to add insulation to change that. Rooms are within 12, 24 hours. Rooms were fine, but there was a lot of scrambling going. Why that happens? Pinnacle had some comments, but they didn't come to help. So we resolved it. So, any questions on the?
Nothing to do with the geothermal, huh?
It was none. But they believe what we did as a solution is the way if you can imagine, in the gardens, there's a pitched roof, and then we have the insulation sitting on top of the flat part of the roof for each of the rooms. There wasn't insulation on the pitch of the roof. What was happening is air was coming up from the soffit, and there was supposed to be adequate insulation covering all the pipes, but clearly that wasn't happening. So we put insulation along the pitch and down along the edge where the soffit would be. And that,
At least you blocked the ends on the side.
and they don't have the same kind of louvers that we do here in the hospital, so we blocked it from the inside.
Right.
But we did.
I don't know why, the code does that for this country, but you don't need it, you don't want it. It's terrible.
But there are requirements that we had to live with. Anyway, we resolved that. So that's the nature of the clinic remodel as we speak right now. And that inspector left about 2 hours ago. So,
Charlie, how did the first snow removal go? You have the equipment you need for taking care of all of that?
I believe so. Now, in terms of the clinic entrance, geothermal hadn't been hooked up yet. So we had snow melt in front of the new clinic. They were hooking up the geothermal today, and testing it will be tomorrow. So that was a little frustrating. Elsewhere, I don't think we've had a problem unless anyone has said or seen if there's been a problem with snow removal.
I didn't see a problem when I was over there. I was here a lot during the snow, so they were out there working like crazy, so.
I think they got a pretty good plan. We've got adequate, we can use an ATV on the sidewalks, so that In the past, we didn't have that, so either it was shoveled or it was, you really can't drive a truck on it. So now we can do that in a much more efficient way. We changed how we plow with our truck. We had I wouldn't say exactly jerry-rigged the front of the pickup, but we did. So now we have an adequate control of our pickup with that heavy-duty plow. So we're getting a little bit better at how we process. And we have adequate amount of snow melt. One of the things about snow melt, when we put that down, sometimes it eats into the concrete.
Nope, so too much down.
So we try not to be real aggressive with that. We don't want to put grit down because then grit comes into the building and now we have dirt. So it's a complicated process. But we think, so if you're hearing of anything about snow not being plowed properly, please let me know. Or if anyone else says it. They're trying to stay on top of it.
Any other questions? Hearing none. Teresa, we're looking at a nursing report.
Turn already? Wow.
Yeah, we're
Guys-
moving right along.
You guys are so fast.
We run a tight ship here.
You run a very. So these are just some numbers for you to look at. I think they're kind of fun. So you might recall about a year ago in November, we got a grant from our liability carrier. And it was for safe patient handling. It was to decrease manual lifting in staff across the board. So we were looking at the primary departments of nursing as well as radiology, surgery, and rehab. So you can kind of see the number of surveys we did. The surveys, we did surveys in November of 17 and then surveyed again in November of 18. And so we've purchased more lifts. We've also added a device that helps us sort of float people on an air mattress from one surface to another. So we use that in radiology, in surgery as well as acute. That's been very popular. So this has gone actually better than I know. It's sometimes more difficult to get staff to adopt some of these procedures. But so manual lifting, if you look at the far right column, you can see that the proportion of mechanical lifts went up dramatically in all of the departments. So we had an increase of 50% in acute, as well over 20% in radiology, and in surgery 70% because they were doing everything manually. So the point of all of this is that healthcare workers who do repetitive lifting over time, it isn't one lift that causes a back problem or a shoulder problem or an arm problem. It's the repetitive lifting that causes that problem. So if we can decrease that, then our aging workforce can last longer. Or hopefully just our staff in general will do better. So I just thought you guys would like to see that. That was really the only thing I brought to the board meeting
It doesn't
today.
look like rehab really has it.
Rehab didn't completely participate in all of this. But yeah, they didn't change things too much. They pretty much do everything manually. So we still have that issue.
You
Yeah.
got some huskies in there.
Well, it's kind of like a macho thing with them. They are so well trained in biomechanics that they feel like they should be able to do this. Now, we might want to, we're trying to convince them otherwise, but we have a little work to do there. So, that's all.
An example of the lifting process that has really made a difference is we use in the radiology. So if a patient comes into our emergency room and they're put on a air mattress, lifts them up, then they can slide them over onto a gurney and into a CAT scan. Right?
Mhm.
What do we call that?
It's, the company's Prevalon, it's Prevalon lift mat, but we're using that, yeah, and really using it a lot in surgery too, so.
So what that does is rather than lift people, you use air to lift them off of the surface they're on and slide them over on that mattress and then release the air. And so it really cuts down on, number one, injury to patients. And it's more comfortable because you're not being yanked around. And it's much easier for staff. We don't have as many.
So we have like little vacuum cleaner machines that blow. And they go in and they blow up the little mattress and then they just, you can literally with one hand just move a patient across.
Really?
Sounds
Yeah.
so space age.
Yeah, it's pretty cool.
Don't push
actually.
too hard, they'll go up.
That's actually true.
But what that does is it really is, it's great for everyone.
Yeah.
It makes a big difference. And it's those kinds of things, especially with our older population, you run the risk of tears, skin tears, or otherwise, they're fragile or frail individuals. This really cuts down on any kind of, not just employee harm, but patient harm. So it's a kinder, gentler way of caring.
Thank you, Teresa. Any other questions?
Any questions for me?
Do they make a larger binder than the one you have?
I'll bring that next time.
Oh, good.
She'll put it on air mattress.
She'll put it on the mattress and she'll not me. Okay. Medical staff privileging. I assume that Charlie will handle this one in the absence of Dr. Graham.
I talked to him earlier today. He was not able to be here right now, but he did. I think we sent out our update.
Yes.
So the renewals are Dr. Gallagher, Paul Winkler, the PA, Stephen Schultz in radiology, and Walter Buell, who is courtesy for works in our emergency department. And then the new is Tara Guile, who's a dietitian, and Kathy Thompson is the PA family practice. Kathy Thompson is also asking for some additional privileging that is unique to, not all PAs are able to do this. And that includes some of she had time in a cardiologist's office, so she'll be doing some of the testing that she's proven her skill on. So that's an added benefit to us. So,
Okay.
Dr. Graham recommends that you approve these.
I'll move.
privileges.
I'll move to approve the medical staff privileging as presented.
Okay, been moved and seconded to approve the medical staff privileging as presented. All those in favor?
Aye.
Passes unanimously. Okay, item number 9, CEO report.
Well, in the interest of moving quickly, since we've had a board meeting, I'll call it quits. No, just kidding. Not that bad. So, but I will, it is, we've already covered a lot of issues. So, first off, we had 2 surveys today. One that finished, the assisted living survey just finished. They left about 10 o'clock, I believe it was this morning. We're here since Monday. While the survey results are not final, they only gave us the verbal results, but they said in their exit description the kinds of problems, and we have issues like with any time. They'll have a number of items that we need to respond to, but they said basically it's going well. They were pleased, they were very pleased with our kitchen and how the staff is handling that. They were very pleased with the process of caring for patients. We had some documentation issues. Oftentimes that's the part that the state focuses a lot of their time on. And so how do we document this or track that? But by and large, it looked like it came out well. They were pleased with certain. That's a very positive. Any questions about the system? We have, brought for you a organizational chart,
Right.
a little information for you. We updated this just recently in part because as part of our mental health services, which is the second page, we had to articulate where people are and how they report, how it relates to me. If you recall, we are what's called the CMHP, Community Mental Health Facility Provider, and then the county commissioners have become the LMHP. It's the next stage up, I forget the acronym, but it's the Oregon Health Authority, the LMHP, to us as the CMHP. And we have reporting responsibilities because the county commissioners can't give up their responsibility. The same thing holds true with public health. There are certain things that the county cannot give up. They can provide services to the county, they can't do it all. So that's why we try to describe this.
Have they still got an active advisory committee?
Absolutely. Absolutely. In fact, they meet tomorrow at noon. And the chairman is Brandy Harris, who is chairperson. Brandy Harris from the school. One of the commissioners is a member of the committee. We have membership from many of the agencies in the community to participate and provide input. The real purpose of that advisory committee, really, is to advise us as a district on what we can do to improve the services that mental health is delivering. We need to they are an advisory not only to us, but also to the county commissioners.
Can we get a report of what their advice is?
Absolutely, absolutely. So far, most of the discussions have been sort of advising the committee of what mental health is doing, rather than they're giving some concerns or input. We have a responsibility to report to the commissioners what we are doing with public health and mental health. So we have, it's supposed to be monthly. The commissioners have not always asked to have that on their agenda, so we try to get there at least quarterly and give them an update on number of visits and what we're doing. But that gives you a sense of the organization and the reporting responsibilities. Just wanted you to have that for your information. Last week, we sent a team of staff members to tour CERN and a CERN facility. They were all very impressed with what CERN can do and came back invigorated to learn more about how that process might work. We're going to be having a meeting, CERN will be back next week, and there'll be some more discussion. And then, of course, the presentations from St. Charles Epic and possibly OHSU Epic to see how that might work. We met this morning with a fourth company, Meditech. You may recall we had talked with Meditech when we looked at CBSI as an option back in 2010. And they're going to try and throw their hat in the ring with their process. We hope to have a plan for your review. The date keeps getting pushed back. I had said at the end of the summer, and then I said by December, but we just can't quite make that happen. It was nice that Cerner sent everyone to Kansas City and to the near town hospital, Missouri, I think it was, that they went to. Remember, that takes them away from their work here. So it's hard to get that all accomplished. Dr. Foster has agreed to be our Chief Medical Information Officer. It's a new position that he will act as, he went along with on that summer visit, very engaged in helping us find the best solution for us as an enterprise moving forward. So it's a great thing to have physician input and able to articulate some variables. So we're pleased about that. We received the signed statement from a psychiatric nurse practitioner, Ellen Mouse. I don't know if any of you got a chance to meet her. She came out in October for an interview, and she will be starting around the 1st of April. She had a long 3-month termination clause with her agreement. So a psychiatric nurse practitioner will be the first time we've ever had that in the county. That will greatly help our primary care physicians. Her principal role will be able to help manage the psychiatric medications as well as some of the addictive medications that physicians are managing.
So she's going to be in the hospital side, not the behavioral health side?
If you recall in our original design for the expansion of the health clinic, the north end is all where we're going to have mental health services. So right now, Jane Lincoln, who is our licensed clinical social worker, is working out of the clinic. She'll be relocating some patients as of 17. Last summer, we had a gentleman by the name of Rick Mashuga. For a couple of months, he was a temporary physician. We thought he had agreed to a contract. He agreed to a contract, but in the last moment changed his mind. So we're making progress with getting agreements now. We just have to get them. So I think that's a very positive thing that will help our docs along and help our community. One of the things that is another exciting thing that's happening as we have been supporting the Klamath Community College RN program. The students have really, as you know, we struggled with our relationship there. We've been working to enhance that, and we've tried a lot to improve that service. In the process, Oregon Health Sciences University School of Nursing has become interested in working with us. And most recently, Carly Alves, one of our nurses here, was made clinical adjunct faculty member of OHSU School of Nursing. That's a very exciting feather in our cap to have someone on their faculty. So we're excited about that. They're planning on having, if they have students that meet the grade, be able to have at least 2 students here in Lakeview doing their clinical work. So we're excited about having more students, but also 2 programs that makes everybody deliver a better service. Last thing that I want to talk a little bit about is issues with parking, specifically at our off-campus locations. We now have 3 places where we have people at the recovery center, the new name of what has been the wellness center, in front of what was the Gardas Headland building. It's now going to be our main wellness center, and then at the Marius building. So we are designating where employees can park and where we encourage clients to go, so as to be a better neighbor. I'm not sure that they've been in the past. So for those that have not or have had trouble with that, we apologize for any inconvenience. But certainly at the Marius building is a prime example, with Advantage Dental having their location uptown. They will have their mobile medical office, dental office there. We need to make sure that their employees park in an appropriate place and still have a place for their clients to park. So we need to be respectful.
Does that mean I'll be able to drive down G Street again?
No, sir, that will not. We will continue to park and make it difficult for you. On the other hand, others will be having no problem. Yes, we hope that that will become, and certainly one of the things that has happened as we have improved access to care is that that means more people are getting services. And as we've had more people getting services, sometimes we haven't been good stewards of encouraging them how to behave in ways that we all want them to. So we're working at improving. And we have some say over them. But we certainly have say where our employees are. you have any questions of, yes, sir?
CNA training, how are we doing on that? We making any progress?
We're struggling with a couple of things. We have been training CNAs, and they have found their ways to other places other than the Lakeview Gardens. So they get trained, and then they go to work at the clinic, or they get trained, and then they go work to acute, which helps those other departments, but doesn't help Lakeview Gardens. So we're going to change some of our processes. When Melinda became the director of long-term, Lakeview Gardens long-term care, again, that changed a little bit of our focus. So part of what she had been working on this past year was to get all of our CNAs, as many as possible, up to CNA not 1, but 2. And then secondly was to add new CNAs. So we have accomplished the first component. Now we're building on that. But we took a little bit of a sidestep as Melinda became more focused on Lakeview Gardens to address those issues. So it is a continuing initiative. And our program to pay for referrals. Leslie is working on a report to tell us how successful that is. We have some indication of fewer turnover, but we don't have a clear answer of how many people it's been impacted, how it's reduced our turnover. We can't give you real specific answers to that yet, but we are working to get it.
Charlie, the Headland Bogarts building, when will that be occupied?
So we have been approved by all the inspections with one remainder, and that is the mental health group. They can't seem to get here, so we're going to do a Skype, walk around with a phone showing them what's been done. They're planning on that next week. It's been frustrating that it's taken this long, but just getting the inspector for the clinics, we worked on that 2 months ago. And the state moves at the pace the state does.
We're getting used to it, Charlie.
I'm not. I'm just perpetually frustrated. It impacts the color of my hair.
But he still has it.
Just wait, Charlie.
Okay.
One last thing that I'd like to add that is astounding. In the last legislative session, the state of Oregon required that certain staffing be established for all hospitals in hospitals, and that there be a very robust survey process to go and ensure that that staffing was being met. We were one of, I think, number 12 or 11 hospitals that was surveyed in that process. To date, I think they've surveyed, even though it started in 2016, and surveying in 17. I think they've done about half of the hospitals. We've submitted plans of how we're going to make sure we comply with the rules. I think we got up to number 7, only 5, my mistake, 5.
That's plenty.
And, pardon me?
That was plenty.
And today, we received notice that our plan of correction has been approved. We now have 45 days when they'll come back to make sure that what we said we were going to do, we're going to do. It's, 45 days within, they will come back, or within 60 days, depending on. It's, as an aside, it's probably the most ridiculous survey process we've ever encountered, but we finally got it approved. And there are very, very few hospitals that have accomplished at least the first level of survey approval. So, great job.
No one in the no hospital in the state passed on the first go, and only a couple passed on the second. So it was, as Charlie said, it's the most difficult survey I've ever encountered, and certainly never had to submit this many
attempts at the plan of correction to get it approved. A lot of our staffing processes had to change. And so the law does not allow nurses or CNAs to do a whole variety of things. They can't miss their lunch break. They can't stay over 12 hours of work. They can't come back in less than 10 hours. There's just an enormous number of regulations around acute hospital staffing now. And so as a result of that, it was a very difficult survey. So we probably have 2 additional FTEs now, or we'll soon have the second one, to do lunch relief so that there's no reason why nurses don't get their lunch ever, which is really hard for me because as a nurse for 40 years, sometimes you just didn't get your lunch because you were busy. But that's no longer allowed in the state of Oregon, so. That's just one of a lot of regulations. We have to evaluate our patients and do calculations so that we have appropriate staff on every shift. And we have to do that in surgery too. So it's all been challenging because as a small hospital, some of the things they require don't fit. They don't fit us at all. And so it's been really hard to figure out how to make those regulations work and meet their expectations.
How do you handle searches of patient care?
It's hard. Really the thing that we have to do is all hands on deck, and the nursing management staff works a lot. Sometimes they're working most of the day and all of the night because those kind of regulations don't apply to nurse managers. So, we're exempt from all those rules. And then the other thing that they expect is divert. So we have to strengthen our divert policy. We have to have the ability for a nurse to ask that patients start being diverted to another hospital, which is also a difficult thing for our community. So.
I do have a couple other things. November 30th is when our cost report to Medicare is due. As of an hour and a half ago, we were notified that the cost report will be finished tomorrow, and we'll be able to see it. We do have a little bit of a leeway of when it is submitted to Medicare, so we're within that time. So we can't tell you exactly what the outcomes of that is. And it is in part, the biggest issue has been how do they handle the returns. And the big issue is including the costs into that cost report for 2017-18, and then it goes back to 2016-17. So that's been part of that challenge. You can expect we will have on the agenda that the audit report will be at the first board meeting in January. So January 3rd, we will have our audit report. We've asked for a draft copy before that time. We'll see if that happens. And last but not least, please remember that tomorrow is our annual Christmas party for employees, and we hope that all of you will be able to be there. It'll be empty house. It should be fun. If not, I'm sorry. That concludes my comments.
All right. Do we have anything for the executive session?
Just a couple of things.
Okay. So we will adjourn for a moment and take a 10-minute break here, and then we will go into executive session.